Hello, my name is Darbey. I'm a genetic counselor and medical science liaison. I'm going to be presenting this article out of nephrology dialysis transplantation. It was published in December 2020 out of the Netherlands and is entitled Genetics First Approach Improves Diagnostics of End-Stage Kidney Disease Patients at Less than 50 Years Old. Some background here, the authors present is mostly information we're familiar with. The prevalence of chronic kidney disease is continually increasing. It is currently estimated that 10 to 13% of the population is affected by this condition. There are many etiologies which can be difficult to identify by routine diagnostics. The monogenic kidney diseases in particular can be challenging to diagnose, and while individually rare, they are not all that uncommon, and they're estimated to account for about 10% of CKD in the adult population and an even greater percentage in the pediatric population. Historically, patients have been targeted to receive genetic testing when they are at higher risk. So have an earlier age of onset, particular phenotype, extra renal features, positive family history. But the advent of next generation sequencing has made this, made genetic testing more affordable. Obviously, it is a minimally invasive procedure, and as it becomes more cost efficient, we really are expanding our understanding of the spectrum of these diseases. So the goal of this particular study was to assess genetic testing as a first-line diagnostic tool by performing testing in a broad group of transplant recipients. The authors sought to determine the diagnostic yield of a multi-gene panel and compare the added value of genetic testing versus kidney biopsy specifically as a diagnostic tool. So the authors discussed quite a lot about their selection process. They wanted to make sure that the population would reflect a typical daily nephrology outpatient clinic. So they were not selective, particularly for familial cases or age of onset or certain phenotypes. Any patient who received a transplant at the center were eligible to participate if they had residual DNA available. The center had started collecting DNA for HLA typing back in 2005. So patients who were transplanted prior to that time weren't eligible because DNA was not available. Patients were excluded if they were no longer followed at the center or if they had a clear non-genetic cause of disease, such as an infection or a nephrotoxic drug exposure. All patients had a review of their EMR conducted to obtain clinical disease characteristics, and whole exome-based sequencing was performed with a focus on a panel of 379 genes. All of the variations within these genes were classified according to ACMG criteria. Some patients in this cohort had actually undergone prior genetic testing and had received a confirmed molecular diagnosis. In those cases, those patients did not undergo additional genetic testing. Instead, their genetic diagnosis was used from the prior analyses. For patients who ended up having a monogenic kidney disease diagnosed and had a biopsy of their native kidney that had previously been performed, slides from that biopsy were re-examined by a blinded observer according to current diagnostic standards. And then where available, prior findings were retrieved from the original pathology reports. A total of 273 patients received transplants at this center under the age of 50 and since 2005. A group of 109 patients did not meet inclusion criteria because they were either not being followed at the center anymore, did not have sufficient DNA available, or had a diagnosis of a non-genetic clearly non-genetic disease. So the 164 patients that fit criteria, 52 of those declined to participate. 2 patients had had prior testing, which revealed variants in a candidate gene, so not a clear diagnosis. And because of that, they were excluded from analysis. Patients who'd received a prior definitive diagnosis were still eligible, as I mentioned, to participate. So there were 40 of those patients who had received a prior clear molecular diagnosis. An additional 70 patients were then eligible to go on to whole exome-based testing on the 379 gene panel for the purposes of this study. So the authors do provide demographic data for both groups. So the group with a prior diagnosis and then those undergoing whole exome-based testing for the purposes of this study. There was no significant difference in the age at onset of CKD or end-stage disease. So you'll see the cohort is nearly all Caucasian. Mean age at end-stage disease was 36 years, and 13% of the cohort, the total cohort, had reached end-stage disease in childhood. So I mentioned that there were 40 patients who previously had identified molecular diagnoses. And then out of the additional 70 patients who were tested on whole exome-based sequencing, 16 patients received a genetic diagnosis. So for the entire 110 patient cohort, this is 56 diagnoses, or a yield of 51%. Additionally, out of the full cohort, there were 6 patients who had their disease reclassified, or at least a subtype further specified. This included cases of FSGS, nephrotic syndrome with normal biopsy, and IgA nephropathy, which were all reclassified as being call for a related diseases. There was also one case of an isolated kidney dysplasia, which was characterized as being part of H and F1B related disease. And finally, there were 4 patients in the cohort who came in with a diagnosis of nephropathy of unknown etiology. One of those patients was identified to have a genetic diagnosis of PAX2 related disease. I mentioned that biopsy review was undertaken for patients who received a monogenic kidney disease diagnosis. So out of those patients who received a diagnosis, prior biopsy samples records were available for 14 of those patients. So in this table, you can see the original pathology observations along with the re-examined histological diagnosis. And the authors do point out there were some limitations here in terms of, information was not always available for review. But overall, in nearly half of the biopsies assessed, so 6 of the 14, the genetic diagnosis actually differed from the updated histological diagnosis. So there was a high diagnostic yield in this study. 51% is a bit higher than we see in many other cases. These patients were transplanted at less than 50, which might be suggestive of more severe disease. We had those 40 patients coming in who already had a prior diagnosis. So those physicians potentially could have been driven by knowledge of the family history or certain phenotype or features that were more suggestive of genetic disease. So the authors did extrapolate and look at the numbers when they included all of the patients with a likely non-genetic cause of disease like infection or diabetic nephropathy or trauma. In that instance, the diagnostic yield would be 21%. So they estimate that the yield is somewhere in this group between 21% and 51%. The reclassification of 6% of cases is slightly less than other studies. We have seen higher yields for reclassification in other papers. It's possible that a good portion of these patients had more recognizable conditions like polycystic kidney disease or nephrotic syndrome. And also the authors recognize that their center has a strong track record in an awareness of genetic testing. So that may have contributed to that. But they nonetheless emphasize that these reclassifications are important and can have major impacts on patient management, specifically treatment of patients with Alport's versus those with IgA nephropathy, as well as knowledge of risks for extrarenal features and needs for referral and monitoring for those other risk factors. The authors also make the point that almost half of the biopsy patients in the cohort would have been unnecessarily subjective to an invasive biopsy procedure had the genetic testing been performed prior to that biopsy. So, they acknowledge that a genetics first approach is less likely in older populations, given the high prevalence of diabetes and cardiovascular disease. So, it may not replace biopsy in all circumstances, but they do emphasize that genetic testing, can provide accurate diagnosis through minimally invasive means at a relatively lower price. They very nicely lay out the broad impact that genetic testing can have in terms of patient management. Firstly, putting an end to the diagnostic odyssey, allowing for personalized prognostication, particularly risk for recurrence following kidney transplant. Second, they discussed that when selecting a living related kidney donor, screening for monogenic disease allows to identify patients with heritable disease and subsequently screen their potential donors, which benefits both the donor and the recipient. Third, younger patients who still are in the family planning stages of life may have the opportunity for prenatal or pre-implantation genetic testing based on knowledge of an underlying genetic disorder. And then finally, for the field as a whole, more knowledge of monogenic kidney disease is a starting point for developing new targeted treatments and options for patients to enter into randomized controlled trials as well. So the authors, I'll end here with their conclusion that patients, particularly those less than 50 years of age, the argument should be really why we shouldn't be performing genetic testing in this population as opposed to arguing why it is warranted.